All right. My name is Rieta Aben. I am an internal medicine resident at Atrium Health Navicent in Macon, Georgia. I am a research associate fellow with Dr. Felix
93456
Sogade.
political commentator and former.
Hello?
Just everyone, please mute their mics, please.
Like I was saying, I am a research associate fellow with Georgia Arrhythmia Consultant Research Institute in Macon, Georgia, under the direction of Dr. Felix Sogade. I've been an AFRA resident member for the past 2 years. So without further ado, I'm really excited about this case that I would want to share with everybody. So I'll go ahead and just start. Uh, all right. So this is a 21-year-old obese male who presented to our hospital for recurrent palpitations. One of the key things that he kept on insisting was just like they keep on recurring, they're worsen on exertion. But however, denied any dyspnea, any diaphoresis, nausea, or vomiting. And of note, he had a prior episode about a month ago that was quite similar and that was successfully treated with adenosine at that time. Now, in regards to his arrhythmia history, just a little bit of a background that I'm going to provide. So he was diagnosed with SVT at the age of 5. However, since then, he's averaged about 12 visits or 12 hospitalizations per year, just to show how recurrent this has been. And at that time, he was treated with several medications, including adenosine, sotalol, amiodarone, as well as cardioversion. Currently, when he presented to our facility, he was treated on sotalol. Amiodarone was previously discontinued, given that his tyrotropin levels kept on rising. So, in addition to that, he had 3 failed RFAs, 4 WBW and SVT at previous institutions. So when he presented to our institution, we kind of knew what we were facing because he had a pretty extensive cardiac history. So in this aspect, he has a congenital heart disease with Situs Inversus totalis and Dextrocardia, pulmonary atresia, a single right ventricle, common atrium, and a single AV as well. He did not have a spleen when we saw him at our facility. And additionally, he had a dilated cardiomyopathy as well as congestive heart failure with an EF approximately 20 to 25%. Now, a bit of his surgeries in the past during infancy included a bidirectional gland anastomosis, a Fontan repair, and a BT shunt. Like I said, the medication that he was on was sotalol and lisinopril. I'm just going to go a little bit into detail in regards to these open heart surgeries he had as a child, which tend to be 3-staged in nature, the Norwood, the Glenn, and the Fontaine. And mainly in regards to this, it's mainly to reestablish circulation. So the Norwood procedure is commonly done during the first week of life, just to reestablish a good systemic circulation as well as pulmonary circulation. And as you can see, the different connections that are occurring on the first image is shown. And then subsequently, a Glenn procedure is done, roughly made at later on in infancy, around 4 to 6 months, to be able to reconnect. So pretty much it's a disconnection of the SVC and connecting it to the pulmonary arteries to kind of alleviate the right ventricle from overworking, because at this time, the right ventricle is is providing both the pulmonary circulation as well as a systemic circulation. Following the Glenn procedure, you then move into the Fontaine, which is the stage 3 surgery. which is now the disconnection of the IVC instead and connecting it to the pulmonary circulation and using a conduit usually. And that's kind of highlighted just above the RA that we're seeing there. So the reason why I also wanted to highlight this particular slide is just to detail how complex the vasculature system is in a patient with dextrocardia, and specifically situs inversus as well. So, which poses a complication when we're trying to do radiofrequency ablation. So on presentation in the ED, his heart rate was approximately 180, showed a bit some wide complex tachycardia. However, there was no cardiovascular compromise during that time. So the plan was to eventually do an EP study. He converted after administration of adenosine and back to normal sinus rhythm. And like I said, his EF at the time was 20 to 25%. And here is a CT imaging just pretty much highlighting how big the cardiomyopathy is and the fact that you can see that the heart is on position on the right side. So this is an initial 12-lead echocardiogram that was obtained on presentation. Pretty fast a rhythm, as you can see. And like I had mentioned before, that was aborted with adenosine. So the plan was eventually to evaluate this patient and get an EP study to be able to go in and really ablate any arrhythmias that was propagating this tachycardia. And of course, on the right is just a chest X-ray showing the dextrocardia as well. So here on figure A and figure B, those are two electrocardiograms. The first being the 12-lead EKG post-adenosine that slowed down the tachycardia and brought him back to normal sinus rhythm. And the figure B is post-ablation. And one of the key things I wanted to highlight here is the fact that to be able to obtain such an EKG, we definitely had to reverse the leads. So the precordial leads were reversed, of course, facing now the right side as well as lead 1 to be able to capture the appropriate rhythm strip. Now, moving on to the image more so on the right, this is a cardio imaging. And as you can see, we have our ablation catheter as well. On the yellow marking, the yellow arrow, it really outlines the AV node that we're seeing. And that's where we were able to go in and start ablating. And again, the biggest challenge was to create a near normal anatomical view, given that this patient had extensive surgical history as well as dextrocardia. So we had to position mainly our view, our cameras in the RAO to be able to see all the images that we needed prior to starting our study. And here is our EP study. I am just going to go over it very quickly. So in the very first one, again, like I'd mentioned before, so the leads were reversed at that time, precordial leads were reversed. And in lead A, we definitely see a wide complex tachycardia. And we were able to induce several of these arrhythmias, although being able to place some of these catheters into this patient's heart chambers was posed a challenge. Mainly the CS and the HIS catheter were present. However, pacing was quite difficult. So we were mainly doing diagnostic evaluations, really using our mapping and our ablation catheters and just trying to detect some of the signals by just placing it, but really not using it as much, just given the complexity of this patient's heart. So like I said, so in the B in the upper right corner, it shows a 2-to-1 A flutter conduction that we were able to see. And one of the key things is that the AV signal that we were able to detect seemed to be coming from the posterior aspect, the posterior septum as well. So that kind of gave us a clue in regards to that this was possibly an AVNRT. So the AV signal was that we were able to detect was of course the shortest signal that we were able to see, and based on that, it was also detecting a slow pathway, which I believe Dr. Sogade can definitely comment a little bit more on it. As well. So a couple of maneuvers were able to be done, but a lot of the confirmatory maneuvers to be able to diagnose an AVNRT were very limited. One of which we couldn't really differentiate an AVNRT with an AVRT on this particular patient. But we were very much confident as the fact that the slow pathway was pretty much detected while we were performing this study. From what we did infer, we did see that it was a typical AVNRT, a slow fast pathway that was observed while we were performing this. Now, just to pretty much highlight and kind of bring this to the forefront, it's just that the complexity of this case really proved that the ablation procedures is very challenging. Number one, vascular access as well as prior surgical scarring poses a really a real great challenge, and being able to just orient yourself given that everything is inversed as well. And then, of course, other things that we were very concerned is as far as was possible recurrence. However, it was quite a successful ablation as the patient was in normal sinus at 3 weeks, as well as 18 months post-procedure. So we were very quite confident with our approach in regards to managing this AVNRT. And one of the key things that I wanted to highlight about this case is specifically patients with single ventricle morphology tend to have these supraventricular tachycardia, specifically AVNRT. According to the literature, that seems to be the most prevalent one. The typical AVNRT seems to be the most prevalent compared to the atypical ones. So, like I said, the fact that this patient had multiple surgeries prior to, of course, him coming to our hospital posed quite a challenge in able to really go in and really test out all the diagnostic maneuvers in diagnosing this AVNRT. And with that, I just wanted to say thank you. And if there's any questions, please feel free.
Thanks, Rita. Thanks for that.
Mhm.
Thanks for that presentation. Wow, what an interesting, complex case that you showed. I'll know where to send my patient if I ever see one of these in the future. Felix, do you want to add anything from your side?
Yeah, I think this was a very challenging case for us in the sense that this guy has had 3 previous attempts at one of our major academic medical centers in Atlanta. He resides in that town, and every time he comes in, we did this case in the evening. He was kind of late in the day, but the way I approached it is that, one, I do not have all the details of his surgical anatomy. And so one of the things we did is that we decided that we're going to reconstruct what we are looking at in terms of cardiac anatomy. So I used intracardiac echo. And because to define the structure, the CS recording and all that we saw, they are more or less far field. That's why we cannot paste from there, because you're recording from baffles or conduits. So we could see signals to give us a clue that this is clearly it's a short RP tachycardia. And so we use intracardiac echo to reconstruct its anatomy. And when we're doing intracardiac echo reconstruction, the only structure you can be confident you identify first is the aortic valve. So you now say, okay, which structure which chamber is connected to the aortic valve? Is the left ventricle. So from there we started create a three-dimensional anatomy to look at, and then we identify the region of the AV node, map out the AV node.
Can we see the fluoro picture with the reconstruction she showed us? Can we
Yes.
please go back to it? This will help us understand you. Yes, I like this on the right hand side. Yeah.
Okay. On the right, yeah. So this is we use the glass-like appearances from reconstruction with intracardiac echo. And so the structure that was drawn up there is the aortic cusp, and then we define the AV node just between the non-coronary cusp, what we know as the non-coronary cusp, and the right coronary cusp. And then we define the AV node. We identify the east bundle potential and define the region of the AV node. And so what we did then was we started mapping the shortest VA time, because there was nothing else we can use as kind of a surrogate. We mapped during tachycardia. So that we decided that we're going to ablate this guy during tachycardia, identifying where the AV node is. So we started mapping the shortest VA time, almost like the way you would map maybe somebody with like a PGRT, or somebody that we mapping the shortest VA time. So in the region where we identify the shortest VA time is where we deliver RF energy and we're able to terminate the tachycardia. But like Rieta presented, we could not distinguish whether this was a septal accessory pathway or whether it's, because all the standard pacing techniques to demonstrate whether an ancestral pathway is present or not was very difficult to demonstrate in this guy, because the only catheter we can really pace is just a mapping and ablation catheter. Everything else that you are recording is in the conduit. We could not do pacing maneuvers from there, and they were like far-field signal. And I said, well, if it's a septal ancestral pathway or it's an Avnrt using a retrograde slow pathway, we will be able to, it's going to give us the same result anyway. My concern was that we got to get arrhythmia elimination in this patient, and that's what we did. And in terms of the fluoroscopic reversal, I like working in RAO view. And so when you're dealing with dextrocardia, you have to turn your camera to LAO to give you the mental image of what you are used to. And people that love to work in LAO, if you're dealing with dextrocardia, you have to go to the other view. So you have to flip that image in your mind as well. So, and that's one of the way, and I think the EKG was also important, that we have to remember that with dextrocardia, I think for some of the your faculty and other listeners, you have to remember to revise your EKG. You have to go back, otherwise the EKG will be totally uninterpretable to you. Yeah. So those are some of the simple things that, that we did, and it did well. Unfortunately, with his cardiomyopathy, he was deemed not a transplant candidate because of the complex, vascular anatomy, and that's the story with this young person. Yeah.
Felix, was there was also a flutter. Was the flutter, did you tackle that as well, or was that just
No,
transient?
we did not tackle that. Actually, after before this time, he was almost in the hospital a few times a month, and they had him on amiodarone. He developed all the toxicity. So I think the flora was more a transient phenomenon. And I looked at that EKG now again, as Rieta presented. I could not exclude that. Was it a 2-to-1 Avnrt? I'm not sure, but because I was trying to guesstimate this cycle length of that flutter compared to his clinical tachycardia, it looks kind of short. That, you know, is it truly flutter, or is it a 2-to-1 Avnrt with the upper turnaround, you know, with block below the node, which is possible. So, but we did not address flutter because I just will not know how to ablate flutter in this guy unless you're doing it on the mitral line or something, yeah, which will be much more complex. But I think that was probably an inter-procedure observation, yeah. We did not see any recurrent arrhythmia in him for over a year and a half, yeah.
And was he ever, I don't know, do you want to comment or got any experience with this sort of complex cases?
Yeah, so can you hear me?
Yes, we can.
Yeah.
Yeah, so there was a couple of points, Felix. There's the bit about the 2-to-1 tachycardia. I was going to ask you that because the tachycardia cycle length was hard to see from this, but it looks like almost similar to the Avnrt cycle length.
Yeah.
And whether or not it's sometimes possible in these cases to, you know, go into the little vestigial ventricle. Sometimes you might be able to see signals to try and pace or do something like that. So trying to peel back the refractory, peel back the refractory period and get the tachycardia as 1-to-1. But I guess that point in terms of this mapping is kind of just trying to work out where the earliest activation point is, and if it's near the node, then I guess it gives you the feeling that we're dealing with probable typical Avnrt. I mean, one of the concerns I usually have with these ones is to locate the AV node, because if by chance you damage it, then you're in real trouble.
Wow, yeah, done. Yeah.
You kind of have to, if you don't, then you have to get arterial access quickly, and I think it's probably it's mayhem. But I always worry about making sure that I've tagged the hiss, identified it, and make sure that I'm sort of miles away from it.
Yeah.
And I guess one other question is, depending on the anatomy as well, isn't it? Because I presume this was was this a lateral tunnel? Because some of the, if this had been a TCPC or it had been anything else, then access would have been extremely difficult. And some of these cases we don't do here. We send off to our colleagues in London who use stereotaxis, because then they can go retrograde into the left ventricle, and then into the systemic ventricle, and then ablate from the other side, so to say.
Yeah, that's where we ablated. This guy was ablated in the left ventricle. I didn't know whether the picture didn't show it well. We went retrograde in the aorta, and then we ablated in the left ventricle. Yeah, sorry, that detail, I guess, was missed in the presentation, because that is the only place we could have real, because everything else that we're recording, I think his vestigial ventricle was not even, we could not get into it. Yeah. All we could get into is that we could even when we cannulated the CS, we could not pace from it. So I think it's all fibrous tissue. Yeah.
Okay, so there was a baffle. It was basically a lateral tunnel that excluded the. Because then I guess the problem there is access to the AV node, isn't it? There's no way but to go retrograde into the systemic ventricle.
Yes. Yeah, that's how it was done. Yes.
Yeah, I mean, these are rare cases, but I guess it's a big win, isn't it, for the patient when they don't have to take amiodarone.
Yeah. I mean, it's kind of it's one of those things that perhaps the guy has a very complex life already, and if we can save him repeated living in the emergency room, and when it comes in, he will spend several days in the hospital before he goes home. So I think it was kind of good to do that. And some of my own experience, I'm an adult EP. I used to cover for a pediatric electrophysiologist when I was at Duke, and that's where you pick up a lot of experience doing some of these congenital, adults with congenital cases. But it's always nice to kind of always understand. I think we need to teach more of the anatomy of this surgery, and I'm glad Rieta covered. What does this surgical techniques mean? What are you looking at when you look at these reports? Because it's very important to have that imagery in your mind. When I was at Durham, we used to open the atlas to look at, okay, this is a BT shot, this is a BT procedure, this is Fontan. What are you looking at? We always have a book open while we're doing the cases. But this was many years ago. This was like 3 decades ago. We didn't have 3D then. But 3D as mapping and some of the intracardiac echo imagery help us to solve this case. Yeah.
And I find when if I'm going to do a congenital case, I usually spend a little bit of time with the congenital doctors.
Yeah.
And go through the anatomy, because often the surgeons will have done something that is slightly unique, as they don't follow this. They won't follow the textbook scenario, and so you'll have to kind of try and dig in. And there are cases where we can get 3D printed anatomy, which is quite useful from the MRI, which gives you a nice anatomical picture of where you are.
Yes. Very nice. Thank you for the comments. I don't know if there are any other comments.
Excellent case.
Thank you.
I mean, I was involved with a Dextrocardia Situs Inversus with an anteroseptal pathway, but with no other complex congenital heart disease. We wrote it up in JCE, and it was a cause of QS waves in V4 to V6 with the leads in the not in the normal position, so to speak. And what I found useful then was to, and on your imaging system, you can ask the radiographer to invert the image. So it can flip it back to what you're used to looking for, but obviously the catheter movement will be in the opposite direction. So I found that quite useful. I don't know. I don't think there are any other comments. Should we move on to the next case?
Yes, Ashley, please. A very nice case. I wish that you presented you submitted to our conference, Cardiorhythm 2025. This and we'll make competition for nice cases. So please, Felix, get sponsored for your fellow to attend with us in our meeting. I would like to ask you, Felix, you used the right subclavian and left subclavian vein to go into the connection, the baffle. How did you get
I went through because this guy has had a Fontan, so we're able to connect through the IVC. I went through the IVC,
So you went from the inferior vena cava femoral vein
to the baffle,
to the baffle. Okay, and you didn't find atrial tachycardia, by the way, because these people have a lot of atrial tachycardia. This is rare to find accessory pathway or Avnrt. You were sure this is not atrial tachycardia.
No, that flora, is it flora? Is it atrial tachycardia? Is it 2-to-1 Avnrt? I guess all those are possible. And I think what Professor Marvat is also for some of the fellows listening, at the anastomotic side, these patients are very notorious for having anastomotic site related tachycardia, especially if they start developing narrowing in the baffles. I know we have a pediatric person online, so I've done atrial tachycardia in some of these previous Fontan patients. But this gentleman, you have to remember, is when approached by pediatric EPs, when approached everywhere, they kind of almost gave up on him after 3 attempts. Because I think the approach that was unique for us, and I think like Muzair mentioned, is really to know, map out the AV node and the east bundle structure, that you don't want to destroy that, because I just don't see how you can get a pacemaker in this guy, because he has a very, very complex anatomy, so we were very mindful of that. And once we got the clinical arrhythmia non-inducible, I said, we are done. Let's get out of here. We're not going to, that's basically where we looked at it,
Thank you very much.
Sorry, this is the pediatric person, Mohammed. I did not comment because I'm on call. Well, I'm always on call, but there's a baby that's very sick, and I was not paying attention so much. But yes, we do Fontan ablations quite, I mean, it's still rare, but like on a routine basis. And very often it's intra-atrial re-entry tachycardia, either in the fontan baffle or into the systemic atrium, in which you need to baffle puncture.
Yeah.
Very unusual to have AVNRT, but we do see patients with fontans and AVNRT, of course, and it's usually very tricky, very difficult. I did not pay so much attention, so I'm not so sure exactly, honestly, what did you guys do? But I do see during the 2-to-1 conduction, the atrial signal is different. Each and every beat, there's slight variation, which is interesting if it was 2-to-1 AVNRT. I mean, if you can, I don't know whether you can, I mean, the screen is so small on my end, but there's slight variation in the atrial signals at the reference catheter, I guess, right? This is a CS catheter, like a reference catheter somewhere, right?
Yeah, it's
And
a
if
single
you,
reference catheter, and you can see. I saw that too as I'm looking at the screen. There is a slight variation
so there's
of the
variation, which is
activation.
against 2-to-1 AVNRT, I would think. But in any case, I'm glad that the patient was non-inducible at the very end, so which is very, which is very good result, of course.
Yes.